Hello and welcome everyone. Today we will be discussing regarding the use of intravenous albumin in critically ill patients. So this is the latest guideline which has been published in Chest this month. This is from an international collaboration for transfusion medicine. So they have made these guidelines of how to use intravenous albumin in our critical care practice. So we all have been using this drug regularly in our ICU. Let's see what the latest guidelines say, when and how to use them. First recommendation is intravenous albumin is not recommended as a first line treatment for volume replacement or increasing serum albumin critically ill patients. This excludes those with thermal injury or ARDS. So this is a conditional recommendation and there is moderate certainty of evidence. The recommendation 2 is avoiding the use of intravenous albumin for volume replacement or serum albumin increase in critically ill patients who have a thermal injury or ARDS. But in case of these two conditions, it is actually a conditional recommendation, but it is very low quality of evidence. The quality of evidence against using this is very low. Similarly, it is also recommended not to use intravenous albumin with diuretics for fluid removal in critically ill patients. This is again a recommendation with very low certainty of evidence. Looking at the evidence that we have till now, we have systematic reviews, that is 16 out of 19 reviews were included, which included most of the broad critical ill patient spectrum. 2019 review with 55 RCTs and 26,000 patients showed no mortality benefit with albumin. And a 2018 Cochrane review with 13,000 patients again showed no difference between albumin versus crystalloids. Coming to specific trials, we know all about the SAVE trial, and 2015 review in trauma showed higher mortality with albumin in patients with a traumatic brain injury. So the rationale of the recommendation is based on the fact that there is no strong support for albumin in reducing mortality or improving other outcomes in critically ill patients. Obviously, there is a cost consideration, especially if you compare with crystalloids in terms of volume resuscitation. And regarding the other usages, like whether we can use it for fluid removal or for patients with ARDS to maintain an albumin level, though there have been studies which have shown some oxygenation benefits, we are not very sure that it is something which can be recommended to be done in the ICUs. Probably we need more trials on those areas. The next is critically ill pediatric patients. The first recommendation is intravenous albumin is not recommended to reduce mortality in patients with infection and hypoperfusion. This is a strong recommendation. And the certainty is low certainty of evidence. Coming to systematic review, there are 3 RCTs. The main one we know, the children involving the African countries, the FEAST trial. The trial 1 showed no mortality difference between albumin and crystalloid. Trial 2, mortality improvement with albumin compared to crystalloid. So coming to the details of the FEAST trial, it was the largest RCT till date in this patient population group, 3,000 patients, comparing saline with 5% albumin and no bolus. The findings were that early termination due to excessive mortality with albumin and saline versus no bolus. No significant difference in mortality between albumin and crystalloid per se. Higher rates of respiratory and neurological dysfunction in bolus groups. So the rationale of evidence is that very few RCTs are done in pediatric critical care patients compared to the adults, and the FEAST trial demonstrated excessive mortality with both boluses, suggesting that probably avoiding a fluid bolus was better, especially that with albumin. Findings may be specific to the patient population that was studied, that is patients with malaria, and fluid administration method, that is bolus versus continuous. Uncertainty exists because it's a very low quality of evidence, but overall if you look at the strength of the evidence, it is very strong. So it is a strong recommendation not to use albumin, especially for fluid boluses. The next population is neonates in critical ill. The recommendation here is intravenous albumin is not suggested to improve the respiratory function in neonates less than 36 weeks of gestation with low serum albumin. It's a conditional recommendation with very low quality of evidence. The next recommendation is intravenous albumin is not suggested for volume replacement for less than 32 weeks gestation or less than 1500 grams. This is without hypoperfusion. Again, it's a very low quality of evidence with conditional recommendation. If you look at the summary of the evidence, hypoalbuminemia review in less than 36 weeks, inclusion 2 RCTs, 36 preterm neonates, no mortality difference, no significant impact on other outcomes as well. Early volume expansion in the population that we have told, 8 studies, 4 with albumin as comparison. The key findings were 1 and 2 studies showed no mortality difference when they compared albumin with saline, and additional RCTs, no difference in terms of infants with dehydration using either of the therapies. So the rationale of the evidence is the very scarce RCTs have been done, only 4 or 8, and a very small sample size, so taking conclusion out of it is very difficult. But considering the cost factors and indirect benefits, it is probably not recommended to give albumin in this patient population. The next patient population is patients who are undergoing renal replacement therapy. Now, intravenous albumin is not suggested for preventing or treating intradialytic hypotension or improving ultrafiltrate in patients undergoing renal replacement therapy. This is a conditional recommendation with very low quality of evidence. So if we summarize the evidence, we have a Cochrane review where the primary trial, a single randomized trial with only 45 patients, compared the two population, saline versus albumin in this patient intradialytic hypotension, and no difference in UF or clinical outcomes could be found. Additional trial, there are 2 small trials with a very small population, only 10, which showed that there was better BP maintenance with albumin, but then as you can see, the population is very less. In 2021, a randomized crossover trial with 65 patients found improvement in BP and UF rates with 25% albumin versus saline. But the rationale of the recommendation is intradialytic hypotension is very common and leads to increased mortality and morbidity. Albumin has a high cost, especially in the absence of strong evidence for its benefit. So routinely recommending albumin for a very common infection would not be a very good recommendation, as you can see, because the strength is very low. Considering the cost effectiveness of other methodologies like midodrine, higher dialysate calcium, in lower dialysate temperature and individualized UF rates may be more preferred strategies. But then if you are really determined to include albumin as a treatment modality in patients who are having intradialytic hypotension, probably you should do that in a setting of clinical trial. So as we have said, we do need more trials on this patient population. The next is cardiac or vascular surgery. Intravenous albumin is not suggested for priming the circuits or volume replacement. It's a moderate evidence of recommendation. The next is it is not suggested for priming or bypass circuit for pediatric as well. That first one was for adult. Again, for pediatric, it is a very low quality of evidence. Coming to the summary of the evidence, a systematic review and meta-analysis, 43 RCTs, 3,800 patients, no reduction in mortality with albumin, so very clear result, no difference in renal failure, minimal difference in blood loss, ICU stay is not different, largest trial had 1,300 patients and higher bleeding and infection rates with albumin compared to Ringer's lactate. So the rationale of the recommendation is lack of any outcome with albumin, and there is a higher bleeding and infection rate in the largest trial. Further studies are needed. There is a large RCT being undergoing in Australia on this particular patient population group. So the next population is patients who are cirrhotic. The recommendation for large volume paracentesis, that is more than 5 liters, to prevent circulatory dysfunction is they are suggesting to use the albumin, and it is a low quality evidence. Regarding SBP, again they are suggesting to use albumin, but it is again a low quality of evidence. Regarding mortality and renal failure, they do not suggest to use albumin for these purposes. Low quality of evidence. Still continuing with cirrhosis, patients who are decompensated or hypoalbuminic to reduce the infection and renal failure and death rate are not recommended to give intravenous albumin. Low evidence. Finally, patients who are having uncomplicated ascites despite diuretic therapy, it is not recommended to give albumin. again a low quality of evidence.
So coming to the summary of the evidence that we have, albumin has shown to prevent circulatory dysfunction and helps limiting mortality in large volume paracentesis. Similarly, with spontaneous bacterial peritonitis, it reduces mortality and renal impairment. But for other factors like extraperitoneal infections, decompensated cirrhosis and outpatients uncomplicated ascites, there is no benefit of using albumin. So as you can see, there are some recommendations which are moderate certainty, that is 1 and 8. The one which were very sure are very less. Most of the evidence that we have is low certainty, that is most of the recommendations that are given over here. The moderate certainty are 2, that is patients should not be given albumin for volume resuscitation in non-burn and ARDS group, and patients who are going cardiovascular surgery in adult, the priming should not be done with albumin. These two evidences are very good and can be followed. Regarding the other, we need more trials because the population and the evidence are very limited. These are some of the studies that are ongoing. If you want, you can go into the details of this. Thank you for your patience.